So let's jump into part 2 of our PT roles with imaging, and let's talk about ordering and accountability. Appropriate utilization of imaging requires several things from the clinician, and it doesn't really matter if it's a PT or a physician, etc., but let's talk about these in our use, and you'll see a trend here as we've talked about some of these already. Excuse me. First one is the quality patient examination from a subjective and objective test and measures, really using your clinical reasoning skills to tie in potential hypotheses that are then ruled up and ruled down with the continued choice of test and measures, which one of those may be imaging. Understanding of appropriate imaging, and we talked about ACRs and clinical decision tools, ordering the appropriate study, and then how those results are interpreted. Now, we as PTs are not radiologists, and we're not trying to be. So even though we can understand the principles of looking at the pictures of imaging and pointing out, maybe where pathology is, that's not our role and our job. And that's a multi-year residency, fellowship, specialization that physicians go through. And so we want to do our role carefully and have an awareness of imaging, and we'll teach you that. But we also want to make sure that you understand the written word of imaging. And I'm talking about imaging that's provided, that's been through a radiologist for their interpretation, not from a chiropractor or others that can use imaging for different things, but one that has been ordered and appropriately vetted through a radiologist who has that specific training of reading images. We want to make sure we can correlate the imaging results with our clinical exam, whether the imaging comes first before we do a clinical exam, or we do a clinical exam and they get imaging and they come back. How do these relate together? Make our decision of treatment, refer, or the combination, and how we collaborate professionally. So we want to make sure that we're doing this well and understanding the roles that we play and in taking results. And if I'm ordering an image, and we'll cover this multiple times, if I'm the one that orders the image, I'm responsible for those results. And so I have to timely manage that and create space and opportunity when I can get those and make those decisions. And so keep that in mind, that there may be times that it's important, they may need imaging, but it's not for us to do. So let's look at some of these considerations. What's my clinical hypothesis? We talked about the variance. Which variant lines up with your hypothesis based on the ACRs? How will these results change my management of this patient? If I don't order them just to verify my hypothesis, I want to order imaging to make sure what's going on will change it. If I'm pretty confident from test and measures in my hypothesis, there's no really reason to get imaging in many cases. Should I be the one ordering? What's the cost and availability of the appropriate study, and what are contraindications and risks to the patient, such as radiation risk? So how could results from imaging change my management? And again, we're not ordering just to see what's going on or just to confirm that, okay, it's an ankle sprain, it's not a fracture, just to rule it out. They don't meet the auto rules or anything like that. But what are ways that it could change my management? So here's a couple of examples. Maybe imaging results indicate a patient who sustained a Fuchs injury would require a splint, cast, or surgery. So think about maybe a scaphoid fracture. How about an imaging may rule out an ankle fracture to allow someone to progress from crutches to full weight bearing? They meet the Ottawa rules, but just because they meet the Ottawa ankle rules doesn't mean they have a fracture. We just want to catch the ones that do have a fracture. And so many of them are going to be negative, and that's okay. And if it's negative, okay, we can get you off of your non-weight bearing, and we can start working on some progressive weight bearing activities to see how you respond. with that. So these are a couple ways that the results of imaging may change practice. So if I have the ability to write the order, should I write the order? And this is a very important question to have. And we've only been exploring this for the last few years, really, in the PT literature. And it started within this Kyle article from 2021 that's in your readings for this session. And so, should the PT write the order? And let's look at a couple of ways for yes and no. So for yes, if I'm located in a health system, maybe within a hospital system, and that can expedite findings or care for the patient without any delay in transport, risk to safety, or delays in imaging reports from the radiologist, then yeah, I could probably order those radiographs. Or if the condition is non-emergent and I don't need results right away, I'm probably pretty safe to be able to order those imagings. But if the imaging results would indicate that there is a need for urgent medical care and the facility they're going to get it from is not readily accessible to provide that care, maybe if it would result in a delay of care due to patient transport, for me sending him to an external facility that's freestanding, that's not tied to a hospital, or if the body region or condition of interest is outside my scope of practice. Those are times when I should not be ordering. I can certainly recommend that they get this and send them off to places, but these are probably times when I would not want to be ordering imaging, because then I will be causing a delay of care. And if that does impact the patient in their function or morbidity, then there could be legal ramifications for that would not be good to face. We'll put it that way. What are some current or urgent clinical hypotheses to be mindful of that probably should just get referred directly without us ordering the imaging? Well, this list here provides a good many of them, although it's not all inclusive. And so suspected fractures. There's times when PTs can do this. You'll see the literature full of times PTs order, but a lot of times the radiology is right down the hall or in the same building, if you will, and they have the ER or the providers there who can splint and cast or make decisions for surgery appropriately. Dislocations, complete muscle tears, hypotheses, stroke, neurologic deficits that are progressive, things that show the patient's worsening. These are all urgent things that we probably need to be not the ones to do the imaging, but yet to refer them to somebody who can do it in a very timely manner. When we order imaging, it's important to kind of note the urgency for which we want the results back. And if I'm the one that orders, I have to stay very attuned to when I'll receive the results. And I got to make sure that it's at the right time and I'm available. If I run my clinic 8 to 5 and I send somebody to get imaging at 3 on a Friday afternoon, I'm like, oh, this is important, let's know, but I close up at 5. And they get there and they wait for 3 hours at the radiology clinic. How do they get a hold of you? Unless you give your phone number and you're willing to do the legwork, or we could have sent them to an ER that could get them managed instead. So we have to think about these, because we are then legally responsible for the results if we order them and the management of that patient until they get to the next provider. And so scope of practice is something important. But stat referral or stat urgency is if we're thinking that, which is like, I got to know right away what's going on here. That's for us, that's probably going to be an active transport to the ER. I'm not going to have a patient drive themselves or a family member if I'm thinking a DVT or significant fractures, a critical region stress fracture like in a femoral neck. These are going to be active transports to an ER to get their workup so they can maintain stability and not deviate and go to lunch and shopping, and then we'll go to the ER when it's ready. If I'm Rex doing this, then this is what needs to happen. If they choose not to, then they're making a decision against medical advice, and that needs to be well documented. ASAP, as soon as possible. Really, we're usually going to contact a primary physician or specialist about how to handle this, because we're concerned. maybe like neoplasm, complete ruptures, maybe like a patellar tendon or a distal quadriceps complete rupture. I mean, there's a time factor that has to be met for optimal surgical repair. High ankle sprains, Lisfranc sprains. There's several things that there's a slight bit of time, but again, we probably aren't the ones who are going to be ordering these. We want to coordinate with somebody who can really be the specialist about what is needed because of the suspicions. Routine things, chronic pain that's not responding to care. We want to look at something else. Maybe we think some lumbar movement conditions that are that affect like not instability. That's more of a neurosurgeon where they want to go in there and put screws and plates in to stabilize. But if we think about someone with some aberrant movements or some laxity, if you will, in the lumbar spine, that could be related to some degenerative changes, you know, that's routine imaging that doesn't need an urgent response, especially if somebody has a normal neurovascular examination, neuroscreening exam. So think about these, about the urgency of what you're going to need in an answer and what you're considering as your hypothesis, because that will really drive if we need to be the ones to order that image or not. Recommendations versus referral. A referral is made directly, and that's your name on there, signing it, saying you need to go here. Here's a piece of paper. Go get this, your imaging done to an imaging center, radiology clinic, etc. A recommendation is made to a referring provider, maybe a PCM or a specialist, that provides your rationale that imaging would be beneficial to that patient. And the details in your note and request are then information for that other provider to make the decision to refer or not. You're just recommending it, but your medical legal record is your notes that cover you because you have done your due diligence and you have a good record there, and then you also document the conversation, the handoff, etc., to close that loop for the continuity of patient care. So what is needed when we write an order, or if I were to recommend imaging for someone? Well, these are the essentials that would go on to this. And first of all, patient name, age, contact information, some basic demographics. What was the mechanism of injury? Where it's located, what side of the body? Clinical signs and symptoms, just the pertinent ones that you're seeing that substantiates that are positive or negative, and the results of any other test. Maybe you did a neurovascular exam, maybe they've had other imaging, maybe they've already had plain films. Put those on here so the radiologist can know what's already been done and the results of that test, a brief result. What you're asking for, MRI, CT, MRI with contrast, etc., and base it off the ACRs. And you can even list the ACR in here if you want, so they kind of know your reasoning, your rationale. What you're thinking. What's the suspicion in your hypothesis through the reasoning process to get the imaging? If the imaging is confirms your hypothesis, what would that hypothesis most likely be? List that down here. That's important because we're the ones who are doing the exam. They're just looking at a static picture. We're seeing this patient dynamically. And so we need to translate all of this to that radiologist. And finally, your name and your contact number if the results are urgent. They may find something there that we think's routine, but they got to call you and say, hey, yeah, there's this, but we're also finding another condition here that we weren't expecting, and we got to get a hold of you soon about that. How do you manage that that information? And so by putting your contact number on here, that's going to help to close that communication loop. So here's an example, and we have a mechanism of injury here. A football player has a left knee injury, and that happened yesterday. And so 28-year-old male football player with acute left knee pain from contact valgus injury during a football game yesterday. Clinical exam has positive effusion, inability to bear weight, valgus laxity with medial joint line opening and a positive Lockman's test. Neurovascularly intact. Request left knee radiographs. You can contact, you can put your name there at your phone number for any questions or urgent results. This gives lots of information. It's very short and concise for a radiologist versus just saying left knee radiographs and nothing else, which can often be done, but yet they're left to guess what you're trying to look at and find, and so they can really narrow down. They'll look at everything on the pictures, but they can really narrow down and give you more because of what you provided to them in their review. So again, this detail is needed. Radiologists don't touch the patient. They live in a dark room and stare at computer screens all day long. And so that's their interaction with a patient. And so you're their eyes, their ears, their touch. You're the senses of that radiologist, and they can only respond to the details or lack thereof that you provide. And honestly, in all my conversations with radiologists, they love when they get this detail from PTs. They love it when you go down there and you want to hang out with them in the dark room and talk about your patient with them and say, hey, I'm looking at this. Can you pull up Mrs. Jones? And I got a couple of questions for you here because this is what I'm seeing clinically. How could this relate? They enjoy those conversations. I have never met a radiologist who wouldn't take time to talk about a case and learn a bit with you in how to manage it clinically. So what does this radiologist do? Well, they diagnose this unknown MSK disorder with conventional radiographs or other imaging modalities. They look at the imaging in the sequence. They look at it from plain films to advanced, if there's needed advanced imaging. They have a systematic approach of looking at these because they're not just concerned about the obvious thing, but they have to look at everything and all the pictures there to make sure that nothing else is present. So that's what their job is. And so they have a very systematic way of doing this. And they have to understand how to demonstrate radiologic features of known disorders. And there's many disorders that can come up in between others because different pathologies will present in different mechanisms or different manners through the radiographs or through the imaging. And so they have to understand and know what those are to be able to give the best response. And if they don't know, then they can recommend what other tools or tests can be done to help get the answer that's needed. They need to be aware of what info is needed by the ordering provider, and so they provide that within the results. And again, the more accurate imaging results come in based on the accuracy and detail we provide them. There's also some limits of non-invasive radiology, so when they just take the pictures, there's limits. But they also can perform guided imaging procedures, such as joint injections. So there's some that get more specialized and use imaging not just to read images, but also to provide treatments as well. Image interpretation. Errors are inevitable. We're humans working through this, and so we always need to correlate the report with the exam. And if you're reading an imaging report and there's something that you see is mislabeled, let it be right versus left or some other error, let the radiologist know so they can edit their reports and do improvements there. So we also want to communicate. So the more thorough we are in our request, we're communicating well with that radiologist. When results get reported, there's a few different ways that they can come out. One, it could be positive for that suspected diagnosis. Our hypothesis was supported. Number two, nope, we don't find here negative exam for imaging, so we don't have our suspected diagnosis. Third could be it's your suspected diagnosis isn't present, but maybe there's something else here. And then number 4, there's times it could be inconclusive. You know what, we can't tell everything off of this. We need to get additional imaging. And the radiologist will usually tell you or recommend what else to get based upon your continued clinical exam. There's a couple things that imaging results could also be, and we could get false negatives and false positives. Sometimes in a false negative, more time is needed for pathology to show. So let's use the scaphoid. For instance, if we have a Fuchs on the outstretched hand and we suspect a scaphoid fracture, well, often that may not show up as a fracture for up to 10 to 12 days. We treat it as a fracture until then, but it could be a false one that says no fracture, but it just takes time for it to develop. And then there's also false positives. And if we think back to our prior lecture where we had our asymptomatic individuals and the radiologist looked for consistency in reporting findings, we can have false positive. Well, there's a finding there, but does it cause a problem for this patient or not? And how do we manage that? So there's several different ways that results can be reported, and it's important to understand what each of these mean for implications in our management. So when you get a result, we want to make sure we read the full results. Usually there's a thorough description of the technique and what was done, and full results, but then at the bottom there's usually a short summary or called impression from the radiologist. Make sure you go through the full results. So in a lumbar spine imaging, the full report's going to talk about each of the levels, where the impression may just narrow down just to the main 1 or 2 findings that the radiologist thinks is giving their symptoms based upon the pathology and what you gave within your order to them or note to the radiologist. We want to share these results with a patient. We're going to call them with results, or especially if it's urgent or at the next clinical visit. And we do this in patient-centric language. And we want to make sure we use words that support, words that help patients, not words that harm. We use clear descriptors of terminology with our patients. And so other providers often don't do this. I've had times where nurses would call patients, and not anybody, not using nurses and singling them out here, anybody can do this. But where they share with patients, oh, your imaging report came back, you have a disc bulge, you might need surgery, and there's a small protrusion that doesn't touch anything neurologically, and the patient has a normal neurologic exam. So patients now are worried, and they don't get all the information. So make sure that you clearly understand and guide through, and it's best to relate these with your clinical exam as you taught. I did this test. I don't see your reflexes, your strength, your sensations normal is not affecting this, and from the imaging report, nothing is touching your nerve roots. I think, and so we can use language and discussions like that with patients to provide lots of detail and give lots of reassurance. They will really appreciate that. But always have a next step plan as you continue your management. What's the next step we need to do? If we need to order more imaging, more tests, hey, we're ready for rehab. Let's get you better. Let's work together and get this taken care of. So share with patients, have a good plan of action, and then make sure that you document the results and what you shared and the questions from the patient that you answered in your notes. Basically, if you haven't got it from the story yet, it's all about correlation. How do I find the images and work the findings from the images with my clinical examination to be able to provide for better care for this individual patient and improve outcomes. So we talked a lot about these roles and responsibilities, but how well do we do these roles? And I think this is probably a great learning point here as we summarize and wrap this up and get ready to start jumping into radiographs in a second module next week. But first of all, Lance Mabry and colleagues here, we did a study looking at various skills, and there's 9 skills here, and these may sound pretty familiar as I list these. Triage the patient, right? Appropriateness to PT care. Utilize evidence-based imaging guidelines. Consider risk and benefit of imaging. Number 4, refer for imaging when it's indicated. Number 5, suggest a modality. Number 6, review the imaging reports. 7, educate patients on imaging findings. 8, integrate imaging findings into treatment plan. And number 9 is refer a patient if imaging findings are beyond the scope of the PT. And each of the ones with arrows that I've targeted here are less than 80%. And skill 5, suggest an imaging modality, that's at 54%. And what we see is that's kind of troubling. It's good that we're doing this. We're doing all the skills at varying degrees, but yet it's troubling that we're not doing them at a level. And 80% is a fairly low bar. You know, if we want to have good consistency and competency in working with patients. Think about what you would want going to a provider. What do you want for your friends, your family, your loved ones if they were going to be seen by a physician, by a PT, and get worked up, and knowing that they can potentially at least recommend imaging, but we're not using all the skills that we should be using. How about if we turn this over to how well do we just do a musculoskeletal exam on someone with low back pain? Am I doing all that I need to do? Or for a patient with a neurologic disorder, am I always doing a good, competent exam and management strategy? Well, it's interesting. At least in imaging, we're being transparent here. We got some room to improve. And so think about this as you go through your review, your notes for this week. We get ready for our lecture and put this together, but also how we approach these next few weeks and really learning about the use of imaging in physical therapist practice. So we've been through quite a bit of material for the background of imaging and PT imaging and a lot of the roles and responsibilities of how we use it. And understanding this, the rest of it just falls into place. But this is the nuts and bolts. We can teach anybody to look at pictures and anatomy. But how do we take imaging as a real clinical tool? That's the important part. And so take some time, reflect on this, and I look forward to see you in our lecture coming up this week. And don't forget to read through the articles and skim through that first chapter in your textbook. We'll see you soon. Have a great rest of your day.